So this is a nice one actually. I mean, and this is the first time I actually told my residents actually around 6 months back that next year is going to be about Amivantamab. It didn't really happen. This I told them last year, but I'm sure 2023 is going to be a lot about Amivantamab because I honestly feel that the days of first, second, third generation are by and large. Aja. How many patients you saw today? How many patients saw today? How many patients did you see today? And how many exon 20 were there? Okay, none, zero. So you are not allowed to sit on the panel. But I honestly feel, we now need to move towards what next in the EGFR setting and what next in the rare mutation setting. We need to move around there. So my first reactions when I saw this topic was about the hidden threat, the Titanic. And don't let your imagination run wild. I'm only going to post this picture of the Titanic for all the men over there. Not going to put the other picture over there. So this is what the common EGFR mutations actually are. And this is what the exon 20 insertions and maybe resistance after osimertinib or dacomatinib actually are. My subsequent reactions on the hidden threat is, you need to have, when you can't run, you fight. So how do you fight this exon 20 insertion and resistance to osimertinib? The molecule here is an Amivantamab, which is a bispecific antibody. And if you look at all the ESMO perceptorships programs and everything, they will tell a lot of ESMO perceptorship programs, a lot of weightage has been given to Amivantamab. This is supposed to be the next big thing in the EGFR space. Sorry Pfizer, sorry Astra, but the future might just be about a bispecific antibody and a chemo antibody conjugates. So let me just start with Dr. Amol. So Dr. Amol, what is the incidence of exon 20 insertions in a clinical practice?
So in my practice, all of a sudden, whatever I have analyzed my data, around 60 patients or lung cancer, can you believe 5 patients were exon 20?
So 5 patients out of 60 is 12% by and large. Okay?
So there is a bias in my hospital clientele because I see more of a younger population.
And why do you see a younger population?
फौज भूल गए क्या?
So what? So what? Okay.
फौज यंग होती है भाई.
Okay. So 12% of all your EGFR. Dr. Shruti?
So I agree, sir. 12 to 15%.
12 to 15%. By the time we reach Vijay Patil, it will become 40% also. Okay, ours is 8%. Next one?
Sir, I saw 4 last year, and before that, I don't know, somehow it was low, but last year I saw 4. This
Okay.
year.
So Akhil, and Vijay in the end, which method do you still use for EGFR testing? So I'll ask this question and I'll ask this to you first and then I'll go to the audience. Are you still using a single gene testing RT-PCR or have you switched over to NGS for all your patients of non-small cell lung cancer?
In TMS setup, actually the turnaround time for NGS is somewhat longer than the other setups. So we still use EGFR, ALK and PD-L1. At the same time, NGS can be sent.
No. So let's say out of 100 people, EGFR testing report is there. How many of them are RT-PCR? How many of them would have gone NGS?
So RT-PCR will be for everyone.
Everyone?
NGS for some patients.
Who are EGFR negative, probably reflex we will send.
Sometimes we don't wait for...
You will send for everyone.
Yes.
Vijay,
EGFR,
is that the
ALK,
same?
PD-L1 plus NGS.
Same, okay. Doctor, this thing, yeah?
Sir, NGS for all patients.
NGS for all patients, no single gene testing. Dr. Shruti?
So we do a small NGS basically for the 5 patients.
No, that small NGS is okay. So it's an NGS panel. You are not doing a single gene testing. Okay, that is fantastic actually. Dr. Amol?
So with the availability of the coupon system and that NCCN 10 gene panel by NGS, so all my patients are going for that. And in those patients, I have also free coupons for the RT-PCR because the results can come in 5 to 7 days. In those, I use RT-PCR, wherein you just send the sample immediately for both, in fact.
Okay,
and
I got your
patients
point.
are sick, basically whatever.
So can I ask the audience, how many of them are using a single gene testing first? Only single gene testing. EGFR, single gene, ALK by IHC, ROS or something, and then send it across for NGS. If something doesn't come into that. Or everybody is using NGS. NGS how many? Okay. And a single gene EGFR first? Okay, in a very symptomatic patient. So, Dr. Anuradha, do you think single gene testing is insufficient for detection of exon 20 insertions? Do you think if I use, I mean, that's what I'm coming to. If you use a single gene testing, you will not pick up the exon 20 as well, and if you use more, it will get more. Is that what we are getting?
If you consider first, I will answer one question that if you are doing in-house NGS, then I will prefer that EGFR should be given as a complementary test within the laboratory. And if at all you are looking for exon 20 insertion, then you need to see which kits are you using. Are they covering the exon 20 in that? And it's just many a times it so happens they only include T790M mutation and not the hotspot mutation, but not the exon 20 insertion. So we need to be very precise which kit are you using for the EGFR single gene testing, and are they covering the all insertions and deletions of exon 20?
Yes, doctor.
I want to comment here one point that when I was discussing about all of a sudden in just 4 months, I got 5 cases of exon 20 and I was using NGS for all patients. So certainly what ma'am has said, we are missing a lot of exon 20 on your RT-PCR kit, and we are not, and it's a heterogeneous disease. It is not one point. Even your RT-PCR, you put 2 or 3 kits pointing out some specific mutation, we are going to miss this.
Even COBAS version 2 has 44 genes which are
Yes.
detected, and that also is not able to detect 30 to 40% at least.
So forget about the exon 20, even some deletion 19s, even some other mutations
Exon
in the
18.
exon 18 and exon 21, you are not going to detect. I mean, I still remember when we were I was slightly more younger, and I used to fight with my molecular pathologist कि मैडम RT-PCR किया था.
You're slightly younger than that time I was a
Somebody checks his blood sugar, man. Okay. Okay. So again, just to say that the threat is real. It actually was hidden because there was no medicine available for that, and it's actually being unhidden now. 10% of data in your EGFR population is going to be exon 20 insertion. 10% is not a small number. For ROS, ALK, MET, NTRK, HER2, tomorrow you have 3-hour session. 9 o'clock till 12 o'clock is, okay, 10 o'clock, 12 o'clock is for all these sessions which make up 7 to 8%. 10% of all your EGFR mutations are the uncommon or the exon 20 insertions. This is the data, 10 to 12% of everyone. In India, you have studies over here which basically says 4%, 8%, 6%, 1%. In our own data, out of 480 patients, we had 10% of people who had an uncommon or this, and that was a single gene. Now we are doing NGS for almost everyone. Again, very important is if you do a single gene RT-PCR testing, you are going to miss the exon 20 insertions. Probably in the NGS you are going to get over there. This is the data from the Jenny database, which basically says PCR misses 49.1% of all the cases. This is the FMI database, which also says that you miss 51.4% of data. So NGS, and more importantly than NGS, please go and talk to your molecular pathologist. Please talk to them about the basics of NGS. If there has to be one class, something which has to be taught to every DNB or DM in their curriculum, that is NGS. I mean, you need to know all those FISH, IHC, NGS, whole exome, whole genome, because things will come onto that. If you don't know, you will never be able to find out what exactly we are dealing with. So, let's say you have a patient of exon 20 insertion, and I'll come to you, Dr. Amol, in the last part of this because we did spoke. Akhil, how do you treat this patient?
Exon 20 insertion, first line, we still utilize chemotherapy plus.
So you have chemo, you have chemo-immuno, you have only immuno, PDL1 80%. So smoker, exon 20, PDL1 80%, and a wink. It's a trick question in the exam.
So we mostly utilize chemo plus Bev in such patients.
Okay.
But chemo plus can be utilized, but we are more happy to utilize chemo plus Bev in such patients.
Okay. Anybody for a KN regimen? I am very surprised you guys from Tata don't know what is the KN regimen. The Kumar Narunoha regimen of Gefitinib plus Pemetrexed carboplatin. How many people will give Dr. Vijay? I know it's not the department, the unit protocol. Today you don't have Kumar to back up on here.
We have the trial for Amivantamab first line, so I'll enroll that patient on
But
that.
the trial is over now, no? Papillon is over now.
हमारे लिए पेशेंट मिल जाते हैं मैं ग्लोबल को मिल डालूंगा.
Okay. Okay. Shivam? So what will you give? If there's no trial, what will you give?
So if there is no trial, actually at present the approval for amivantamab is post platinum failure. But I think I've seen the patients on the trial, so I would actually discuss with the patient and see if he can access amivantamab.
The trial of the Papillon study, which I think we also had, was amivantamab plus chemo versus only chemo followed by amivantamab, was a fantastic trial. It's a pity India only got some 20 patients out of that. We should have got more patients, but that's okay. Shivam, what will you do?
Sir, 2 patients I have used the KN regimen and they are 1 year post. In both of them are exon 20. So I have a lot of faith in KN regimen.
The KN regimen did not actually include exon 20, by the way. It was just a trick question.
No, I am telling you. So I have used it. I use it in all uncommon mutations where
Okay.
I don't have a direct answer.
Okay.
And somehow they respond very well. And I have 2 patients who are doing
And that brings me to a yes, Vijay.
I think we also should discuss about that A763 by 764. That is that is sensitive to first line TK. So it's not
again,
at every exon 20.
That is also very, very important. I didn't miss up. See, not all exon 20 insertions are same. Some of them actually are sensitive to afatinib and osimertinib also, and you should again talk to a molecular pathologist. But that brings me to a very important point about afatinib. Shruti, you know, the moment you see something rare, which is not del19 or L8581, you use afatinib. And I have been guilty of using this because my only residents analyzed the data, sir, क्यों दिया था? I said किसी और ने दिया होगा यार, मैंने तो नहीं दिया था, handwriting मेरी थी.
So for exon 20 insertion, I will not choose afatinib. I'll go for chemo plus.
Why will you not use afatinib?
So the data is
So the data is very sketchy, fantastic.
sketchy, and I have personally not had good experience with that. So unless and until someone insists on oral treatment, unfit for anything else, I'll use chemo plus Bev or chemo plus immunotherapy.
Okay.
So for your patient, the PDL1 was also positive. So why not chemo plus
Typically immunotherapy can be used, but I think chemo plus Bev or chemotherapy is the right one, which brings me to Dr.
So
Amol. Yes.
ABPC regimen is
ACBP
also,
regimen
yeah,
can
so
be
ACBP.
used in that. Fair
That
enough.
is.
But that again took, Dr. Shruti, it again took only the common EGFR mutation. It did not take the exon 20
No,
insertions.
so it took all. There is a.
I don't think, if I remember rightly, it took only del19 L858R. But I can check again. Dr. Amol, afatinib plus bevacizumab, and that is why this question is being reserved for you.
I am using it.
You're using it, and the reference for that?
No much of data, but there is no, the way Akhil has said, the bevacizumab he is using. So exon 20 perhaps is such a bad disease. Whatever my experience I had with the patient, immediately after 4 months they develop brain mets.
So true
And
that.
just
So
to-
what I basically want to show and say over there, which is also said, all EGFR mutations are not created equal. EGFR exon 20 insertions are bad. The PFS is less. The OS is less. This is what data which basically showed, you can use platinum based TKI, IO alone. It does not work in this. Now this is for you afatinib data. This was again a trick question, and Shruti very rightly did not fall into the trick. So this was because this is very, very important. When we used to speak about rare mutations sponsored by BI, we always used to think, anything which is not del19 L858R is uncommon and use afatinib. But that is not right. This was a pooled analysis. Again, you see uncommon mutations are 3. A, the point mutations are this thing in the in 18 to 21. Second is de novo T790M, and third is exon 20 insertions. In exon 20 insertion, you have an exact response rate of 8%, a median duration of response of 7.1, DCR of only 15 people responded. Again, the data was not very, very good. So now, you have given pemetrexed carboplatin, and the patient has progressed after 6 months. Dr. Amol, what would you do now? Same options. You will look for a clinical trial, or for what?
Yeah, just before coming to this question.
Yes.
Prior to your slide, it is not the combination, I believe. Here
Of?
you have Of the afatinib plus chemotherapy.
No, that was not.
Yeah. So
There was single agent afatinib.
that's what I said.
Yeah.
You have that.
Yeah, so afatinib plus Bev or something can be used over there, but again, it is not a very mouth-watering approach. So what is preventing you from using only chemotherapy?
So obviously chemotherapy has not shown any good benefit.
And same afatinib also has not shown.
That's why I'm saying Kumar and Narona are there.
The KN regimen. KN regimen did not take...
The way similar experience I have with the
So then we should pool our data and report it. Right? But again, typically tell me about the KN regimen. Did they include exon 20? I'm not sure they did. Yeah.
In fact, we analyzed our 22 patient data which you showed 8.8. We had pathetic outcomes with chemotherapy.
Yes.
Our median OS was 5 months.
Yes, absolutely right. So I mean, similarly here we are median OS is 7-8 months, so it doesn't really.
Chemotherapy is not going to help.
Yeah, that is why.
The data, whatever you're using, like I'm using afatinib with the chemotherapy.
Absolutely okay. So if you look at this also, Dr. Amol, you know, the point here is people have used everything. See, if you look over here, people have by and large used everything. You know, you can use chemo, you can use DKI alone, you can use this, you can use OCBD. It doesn't really work. I mean, that is what I wanted to show. Second line, what will you do?
First, regarding the previous,
Yes.
mutation is towards 763, 764 side, and we are much more comfortable using the KN regimen.
The KN regimen. Fair
We
enough.
know that it has somewhat
Fair enough.
better
Fair
sensitivity
enough.
to
Fair
EGFR.
enough. Fair enough.
Second line,
Post chemotherapy, you're taking?
Yeah, post chemotherapy,
Obviously, we have access to
Amivantamab.
That's the best.
That's the best, but very costly. Okay. Anybody else has
The other
a?
thing is one of my patient or the combined patient with the TMH, mobocertinib is.
Okay, so mobocertinib also can be used. We'll come to that also.
compassionate access is still available.
So
That's
again,
the best part.
So again, there is no standard regimen for treatment beyond exon 20, but that was before the Amivantamab study. And what Dr. Ashish rightly showed over there here was that this was the study. Again, the dose you have to remember, it is a weight-based dose. Less than 80, you give 1050. More than 50, you give 1400. Very importantly, infusion reactions. Do not just give and leave it on the sister, because if you leave it on the sister, you will have to come out of your bed and go to the patient and see in the ICU. People do get infusion reactions around that, and that is what you should actually know. Again, the overall response rate was 40, duration of response rate of 11.1, benefit response rate of 74, median PFS of 8.3, OS of 22.8. 22.8 doesn't look great, but what is the OS in here we come, the KN regimen. Finally, I have been waiting to hear the KN regimen here, no? Okay, the median OS is only 22.4 months, and that is what we can see over here. Important thing again, there was a lot of talk about, you know, whether the insertion is within the loop, near the loop, or the far loop region. But in this study, they said anti-tumor responses were observed across all the exon 20 insertions. So a lot of time we said if it is near the loop, we will use mobocertinib. If it is across the loop, we'll use this. But I think that is thinking a bit too far, and we need more data.
But PDs actually happened only near the loop.
The near the loop, yes. So maybe, you know, we need to know about what the exon 20 insertions what. Again, you have got company. It's not that you don't have a company or got company. Mobocertinib basically had approximately same 28%. Duration of response was higher. But again, if you see the median OS is 20.2 months. Very importantly, minor increased toxicity with prior immunotherapy, and a higher dose has got more diarrhea. So if a patient is, you know, willing to accept oral, he wants oral, more diarrhea, more pneumonitis, mobocertinib. If it is not infusion reactions, you can probably give Amivantamab, and that is also good. So anybody's clinical experience?
I think Amivantamab, if you give it according to the first day dose of 350 dividing dose,
Yes.
start with 50 ml per hour and then jump to 80 ml. I think the infusion reactions are literally settled with that kind of.
So we started with that in our patient last week, and we have had a good reaction on that. We had a good reaction with that.
So what I do is I give it like rituximab. So first
Slowly.
vial, open it, give it like rituximab, same pre-medications, and patients are able to tolerate. I have 2 patients, they tolerate very well, sir.
Okay, and how has been the side effects and the infusion?
So rashes, basically they develop rashes as the.
So the drug is reasonably well tolerated. There are only 2 major side effects. One is the EGFR wale and one is the MET wale. So EGFR wale, you will get the rash and the paronychia, and the MET wale, you will get a bit of increased edema and stuff like that. That is what you probably do get. Any clinic? Yes, please. Yeah, to Vijay, yes, Dr. Vijay. Dr. Vanita wants to ask a question to you.
No, it's to the esteemed moderator. No, so,
Esteemed moderator went, madam, in the morning.
no, so seriously, this near the loop and all, I cannot understand. Amivantamab is an antibody, na, so what it has to do with the loop? Loop to under hai, na? So
Yeah.
it's working outside. So why should it have more efficacy near
No, I think,
far loop, etc.?
You want to take that?
I don't know, ma'am. What you saying is correct. It's actually an antibody, and if you see the mechanism of action, these mechanisms of actions have nothing to do with the TKI domain. Sorry, it is everything is extracellular. I think it has to do with the biology of that.
No, I think mobocertinib acts intracellularly. So that is why mobocertinib will act more. That is why probably saying amivantamab becomes lesser. So it's not about amivantamab not acting. It has become mobocertinib acting slightly bit more. That is probably my explanation for this. So there are two trials. Ultimately, I think it will come down to, nothing really changes. In the long run, you will find out nothing really changes. So there are two clinical trials that we are having right now. One is the Paloma 3, in which you are comparing subcute amivantamab versus the intravenous one. That is going to start recruiting. And the Mariposa 2, which is after osimertinib failure, where you give amivantamab plus chemo versus only chemotherapy. And conclusions, basically, they are new weapons to neutralize the threat of exon 20 insertion. Again and again, the diagnosis is the key to the treatment. Are we moving towards NGS for all lung cancer patients? My answer probably is yes. It is approved only for second line. Please don't call up for the first line unless you're Vijay Patil and you can talk to the global team and you'll get the trial, not to us. The common side effects will include infusion reaction, nail changes, paronychia. Our trials are underway to better understand and utilize this new drug. The threat is neutralized. The session is over.
Why not in first line?
So the data is not yet there.
You everything else, you sort the response rate for 5%, 10%.
Correct.
And here you have in second line, the median lines of therapy
Vijay, I think the answer has got more to do with the medical legal issues right now and the approval and the PAP. There is no doubt that the data will be stronger in the first line. But you need to wait for the data. We just cannot, the people will come to you only for a second opinion regarding that, no? With chemo, yes, right now.
So there was another trial was going on, the Chinese IO plus amivantamab, 3-arm study. Anybody aware of it?
No. That's the Mariposa 2. That's the Mariposa 1 and 2. Mariposa 1 is the one where they are using common. So the question actually for me is more to do with Mariposa 2 and 1. This is an antibody which has got dual this thing against MET and EGFR. Then why are we giving it for everybody post osimertinib resistance when we know only 40% will get? The question will come over there.
So actually, we had this discussion with Dr. Sir is not here. One of the patient actually who is post osimertinib, and we had a lot of discussion on this. And this data is unpublished, and he had contacted a lot of scientists. There's actually good data which would come in public domain very soon, which says that even if you don't have MET
amplification,
it works.
There are multiple various mechanisms of action for this. Probably that is how. But again, amivantamab definitely in exon 20 and probably in patients post osimertinib is going to be a major role to be playing in the treatment of EGFR mutant non-small cell lung cancer. With this, thank you. Thank you for a wonderful discussion.
We
Yes, Dr.
discussed a lot about exon 20 insertions, but we also do get S768I hotspot mutations. So what is being done about that? What is the treatment available?
Afatinib. S768I, please go ahead.
Afatinib or osimertinib for me.
Both are available. And sir has analyzed that in detail, and the data for afatinib is much better with S768I than with G719X.
Yes.
G719X, though afatinib has a label, but it's still not so good.
Yeah, I agree with him. For G719X,
So
G79X, we now, G79X, we will prefer actually Jeff plus chemo.
yes,
That
that's
is
okay.
Cambridge.
That's okay. Yeah. Okay, thank you. Karo. Now you're going to get bored of me. Okay. So now I am going to talk about something which is I'll take it. So now I'm going to talk about the continuum of the care in metastatic non-small cell lung cancer with ramucirumab, the REVEL study. And these are the disclosures that I have, and this is where we have. And the first indication that the study is not very good is the fact that Dr. Vanita is moving out of this. Bye. Okay. So, if you can see people disappearing from there, that is the first indication that chalo purani study hai. So, how do you target the second line combination treatment of metastatic non-small cell lung cancer? And my first reaction when I actually look at the REVEL data is this. I mean, you know, Revel data came in 2014. I actually looked at my presentation in 2017 and I said, yeah, ये तो पुराना हो गया ना, it's like a history channel. And it's not my problem. Now we deal with immunotherapies and everything else everywhere. My subsequent reactions about Revel data is like, you know, you should always never run from the history, and you should learn from it and embrace it, because those who do not learn from the history are doomed to repeat it. So let's get real about immunotherapy in lung cancer, and the TMH people are not there. Out of 15,000 people, 9,610 people, only 1.61% people could receive immunotherapy. Let's get real about this. This is our studies, a metastatic experience where we found out 74 patients only we got in last 4 years. Again, our own study, only 60 patients in 3 years that basically we got for immunotherapy. So, you know, and we see like around 700-800 patients per year. So we need more data about non-immunotherapy also. That's definitely a point that we have to make over here. So let's start with a 45-year-old female. NGS there's nothing. We give 6 cycles of pemetrexed carboplatin, and it's a progressive disease at the end of it. The options of the treatment that we have, let's just go back in time right now. Now let's look at the only approved option in this patient, that is docetaxel. Now docetaxel at 75 milligram per meter square has a response rate of 5.5 to 6.7%. I'm sure if you want to fail your DM or DNP candidate, just ask them how much is the response rate with docetaxel in the second line. OS of 5.5 to 7.5 months and a 1 year survival of only 30%, and that is what we were all living with till something new came actually over there. Pemetrexed versus docetaxel, the graphs are absolutely superimposed on each other. There was no advantage of pemetrexed over doci. The only thing was the quality of life was slightly better with pemetrexed, and that is how the pemetrexed got approved. Now, just to get some more this thing in this, do we have, Vanita has gone, whom do I catch? Okay, I'll catch Dr. Mishra sir. Sir, can you identify the star? Anybody? Amol will tell. See this. Thank you. So this is fantastic, you know. Okay. So this basically brings out to us that there's an unmet need over here. You want something to go upon docetaxel, and that is why the Revel study was designed. Important things only, and I'm not going to bore you much about it. First of all, both squamous and non-squamous histology patients were taken. That is the most important thing. Not only non-squamous was taken. Again, if you look at the number of the patient, 1,253. That's huge number. That's not a small number. People were randomized between doci and ramucirumab versus only docetaxel, and the primary endpoint was the overall survival. Again, the exclusion criteria were untreated CNS mets, but if you had asymptomatic brain mets and treated, they were actually eligible. However, major blood vessel invasion or encasement by cancer or a significant intratumor cavitation were excluded. So this is something which you need to know. Just because it is squamous, you don't need to exclude these patients actually. The results of this trial basically showed that there was a significant, there was not a significant, there was a good improvement in the overall survival. There was not a good improvement, there was a fair improvement in the overall survival. 10.5 versus 9.1, 4.5 versus 3 months, and 23% response rate versus 14% was what basically we were getting. This is the primary endpoint. This trial was positive. Again, please remember, when the data get published in 2014, there was no immunotherapy. Immunotherapy started coming in 2014, 2015 only. So this was 10.5 versus 9.1 in the intention to treat population. Both the squamous and the non-squamous patients did actually benefit from here, and it was slightly better in the non-squamous one, as we very well know, which is the usual case. The primary endpoint, the PFS also was better with the ramucirumab and in the ramucirumab arm. Again, the overall response rate was better both in the non-squamous and squamous, with squamous actually showing a slightly better response rate as compared to the non-squamous one. Important thing, what were the side effect profile? And the side effect profile was there, something which was more in the ramucirumab docetaxel arm was febrile neutropenia, and the neutropenia plus mucosal inflammation and some peripheral edema. So this was the side effects which was increased more in the ramucirumab arm. But what usually used to concern us was the GI hemorrhage, hemoptysis, pulmonary hemorrhage, and those were not increased in the ramucirumab plus the docetaxel arm. So that is something which is very, very important. The drug is safe, but you have to choose your patients very, very wisely. Again, the side effect profile was consistent. It was not that the squamous histology had more, problems. The pulmonary hemorrhage, the GI hemorrhage, the venous thromboembolism was similar in the squamous versus non-squamous histology. That was very, very important. So that is something which was there. OS advantage of around 1 to 2 months, but that's same what you usually used to got with the pemetrexed versus gemcitabine cisplatin also. 1.2 months was the advantage. Now, what about the aggressive disease? And this is exactly how Amol is looking at me right now about the aggressive disease. Aggressive disease is basically looking at people who do not respond to the first 3 cycles of chemotherapy also. So you give chemotherapy, out of 1,253 patients, 17% people did not respond to the response rates also were higher, 19% versus 9% and 23% for 14%. So maybe enough patients who has not responded to the first chemotherapy, second chemotherapy, docetaxel plus ramucirumab actually works more. Now, what about the Indian patients? We always look at the Indian data. This was an article which was published in the CRST in 2021, and both Vanita and Kumar have conveniently disappeared from here. They basically looked at the Indian subset of population who got ramucirumab and docetaxel, and these were the graph. I think 55 patients were taken. Dr. Doval, Dr. Chirag Desai and Kumar were the lead authors of this study. And this study basically in the end said that, in the clinical practice, ramucirumab may therefore be considered an important therapeutic option for Indian patients with metastatic non-small cell lung cancer whose disease has progressed following the platinum-based chemotherapy. So it's nothing great, but the point over here is, we were having a discussion about the pulmonary sarcomatoid carcinoma. The options that you have are also not very great. This may just be a very small, minuscule benefit, but then this benefit is actually over there for everyone to see. Now, there are a lot of people over here who use a taxane-based regimen, or who use, people were telling about Bev plus chemotherapy. So can you use ramucirumab plus docetaxel after that? And yes, you can. So it did not make a difference whether you use paclicarbo, gemcarbo, pemcarbo, or nevilbene carbo. Ramucirumab plus docetaxel helped and was having an equal benefit as compared to everybody else. So it does not really make a difference what was the initial regimen that was basically used over here. Now, that was all there before in 2014. Is there any relevance of this data in the year 2022 when there is an era of immunotherapy? I mean, that's what. So the history channel also has evolved from 1995 to 2008 to 2014 and now. So is there a relevance of this drug combination of dosi plus ramucirumab in today? I think there's a relevance, and I think now there is a more relevance than what it was before. So what happens when your keynote 189 or a keynote 407 or a keynote not 24, once the patient progresses on that, then what do? You are basically left with only second line chemotherapy of taxanes or something else. So this was an analysis which was done by the German group against 77 patients from 9 thoracic oncology center. They gave platinum-based chemotherapy and immunotherapy, and then they checked then they gave the patient ramucirumab and docetaxel. And again, the amount of chemotherapy, immunotherapies was basically pembro, pemcarbo, paclicarbo, atezo, durvalumab, all sorts of combinations were basically given. On progressions, all of them got dosi and ramucirumab, and the data basically is a median PFS of 3.9 months, a duration response of 6.4, and an OS of around 7.5 months in the second line setting. So there is some amount of this, of some benefit that you can get with ramucirumab and docetaxel. So to conclude, it's very fascinating to use immunotherapy and chemotherapy in the first line. But you need to remember this is a test match. If you looked at the Bangladesh score today, there were hundreds or something for 0 and they're 272 for 6 right now. So every member of your team is very, very important. It takes a lot of people. Maybe your second line, third line, fourth line are equally important. It's not only about the first line immunotherapy. And in a team effort, if you don't have this lady sitting over here, then probably the entire jigsaw puzzle will not pass. So immunotherapy and chemotherapy definitely is there, the stars, the Shah Rukhs and the Salmans and the Varun Dhavans over there. But you also need to have a look at the second line regimen, and we need to optimize the second line regimen also in our clinical practice. So with this, thank you. And if there are any questions, I don't think I'll be taking them. Thank you. Yes, we have a question. So ma'am, there has been no consistent data of Bev has never led to an OS advantage. throughout all these things, Bev has got an increase in PFS but never got an increase in OS. So that is the thing. But yes, people do give it all the time. Yes, Pashish.
Use of taxane upfront, albumin bound, especially to avoid steroids. So where do you figure, like here a lot of pemetrexate is being used in the frontline setting, and then using taxane?
So I think the REVEL data did show that, whether you give taxanes earlier or not, it does not make a difference. So in fact, in the initial docetaxel trial also, all the regimens were used. In fact, at that time, pemetrexate was not even in vogue. See, this data came in 2004 or 2003. So you can actually give Gemca, Paclitaxel, and then use docetaxel. They can be used interchangeably. There's not much difference in the. You can give dosi after Paclitaxel. That's what I'm saying. Okay, thank you.